Welcome to part 4. This is our last GU section, and we're going to focus on how to care for indwelling or Foley catheters and how to prevent infection. Indwelling catheters, are also called Foley catheters, are special catheters we insert into a person's bladder to empty their bladder of urine. We do this for several reasons, which are actually dictated to us. We can use them to relieve an acute urinary obstruction, meaning something is blocking the urine from exiting the body. We can use a catheter to obtain a sterile urine specimen when the person cannot void voluntarily. We can do this to have the most accurate urine output for critically ill patients. We can do this to help heal an open sacral wound in an incontinent patient. We can use them to empty a bladder in times around surgery or diagnostic procedures. I will say that these are dictated to us because CMS, or the Centers for Medicaid Medicare Services, actually tells us when we can and cannot use an indwelling catheter. You might be wondering why. Well, indwelling catheters have such a high risk of infection that the benefit to having a catheter is usually overshadowed by the risk of an infection. The risk is so high that CMS had to get involved and created a bundle of care telling nurses and providers when they can place one and how to care for them. This bundle is called CAUTI, or Catheter-Associated Urinary Tract Infections. And anyone who doesn't follow this bundle and the person gets a UTI will have their costs denied by Medicare and the hospital will lose money. Sadly, infection isn't the only complication associated with indwelling catheters. They can cause people to have horrific bladder spasms that are extremely painful. They can cause urethral strictures, which is permanent scarring of the urethra, making voiding difficult. And if that weren't enough, indwelling catheters can also cause pressure necrosis of the urethra. This is when the tissue of the urethra and surrounding areas die and that tissue does not grow back. The first part of the CAUTI bundle focuses on insertion. We insert these sterilely, like majorly sterile. We do not break sterile technique, and if you do, you're going to stop and you're going to start all over again because any bacteria we insert into the bladder will cause a UTI. We need to educate our patient on every step of the insertion process. We're going as up close and personal to a person as we can, and they need to know everything we are doing to help them feel more comfortable. We need to make sure our patient is prepped and positioned in a way that will allow us to maintain sterility. Once our gloves are on, we can't touch anything. When we insert the catheter, we need to minimize trauma we cause to the urethra by using an appropriately sized catheter. Honestly, sometimes we just use what catheter we have available to us. We need to use a water-soluble lubricant. If we have a male patient, we can get an order for lidocaine-infused lubrication. This is called a Urodret, and it numbs the male urethra. We want to insert the catheter far enough so we don't accidentally inflate the balloon in the urethra and cause trauma. We also need to make sure we secure that catheter properly, hopefully with a commercial-made product like this picture of a Statlock. The second part of the CAUTI bundle discusses what we need to do to maintain the catheter to prevent infection. First, we need to be doing good perineal care at least twice a day. The perineum is very moist, it's bacteria-laden, and if we don't clean it often, the patient will develop an infection. It's not an if, it is a they will develop one. We also need to make sure the patient stays well hydrated. We need to make sure that we keep the Foley bag system closed, meaning we don't take the catheter and the bag apart unnecessarily. We need to make sure that we clean the drainage spigot with alcohol every time we're emptying the bag. This is going to help kill bacteria. We also need to keep the drainage tube free from kinks and keep that bag lower than the bladder, but not on the floor, to help prevent any old urine from going up the bag, up the tube, and going back into the bladder. We also need to wash our hands before and after we drain the bag and wear gloves at least every 8 hours or more if the bag is getting full. And the last thing we need to do is chart daily necessity. CMS dictates when we can use the indwelling catheter, and we must document that the catheter is still needed. If it's not needed, it must come out. and this information is all reportable data to CMS. The last thing we need to do is frequently assess our patient for signs of an infection. Because the patient is not urinating, because that tube is doing that for them, they won't have any burning or painful urination to tell us something is wrong. So it's up to us to assess the patient. We need to look for signs and symptoms of an infection: cloudy, malodorous urine, maybe hematuria, fevers, possibly chills. We're going to diagnose the UTI by doing a urinalysis and finding positive nitrates and bacteria. CAUTIs can get very serious very quickly, turning from uncomplicated to critically ill in days if we don't assess the patient. Because this infection is now a facility-acquired infection, the bacteria may be harder to kill, so the patient's probably going to require stronger IV antibiotics instead of oral antibiotics. The stronger treatment can have side effects that can delay patient care, extend their stay, and cost more money. This is why CMS got involved. They didn't want to pay for all of this extra care when this problem is caused by poor nursing care. Nurses own CAUTIs. We own the infection. They occur because of us. They also don't occur because of our good nursing care. So nurses really own these infections, and we need to do everything we can to prevent them. And this is the end of GU.